Please welcome to the stage AFTD's Director of Support and Education, Esther Kane.
So welcome back, everyone. My name is Esther Kane, and I am AFTD's Director of Support and Education. This next session will focus on the individual needs of FTD care partners. Everyone in this room knows how frustrating and emotionally overwhelming FTD can be for families. Given its relatively young onset of age and its particular symptoms, FTD can be challenging for the care partner and caregivers who provide support for their loved ones. We're going to look at some dementia support programs that have been adapted to FTD and highlight the federal public health initiative known as BOLD, which shows promise in better supporting dementia caregivers in the future. First, I'd like to introduce our speakers. We have Dr. Joseph Gaugler, who is the Robert L. Kane Endowed Chair in Long-Term Care and Aging, and a professor in the School of Public Health at the University of Minnesota. We have Allison Lindauer. She's an associate professor at Oregon Health and Science University's Latent Aging and Alzheimer's Disease Research Center. And Dr. Darby Morhardt. She's a professor in the Museum Center for Cognitive Neurology and Alzheimer's Disease and the Department of Preventative Medicine at Northwestern University's Feinberg School of Medicine. Welcome, everyone. Thank you. So, Allison, can you just give us a little bit of a brief description of some of the research that you're doing?
Yeah, thank you. So nice to be here. I'm Allison. I'm two things. I'm a scientist and I'm a nurse practitioner. And as my work as a nurse practitioner, I work in the dementia clinic where I see families living with dementia. Since 2016, I've been working on an intervention adapted from Linda Terry's STAR-C work that helps families understand difficult behaviors, understand what comes before them and how to address them. I've been doing this research, and during my clinic time, I noticed a difference between the families living with FTD and the families living with Alzheimer's and similar dementias, and I couldn't quite put my finger on it. So I sought funding from the AFTD, was able to secure the Wellbeing in FTD grant, and was able to establish some focus groups and with families with FTD and talk to them about what they would want if they could change the intervention, how would they make it work for them. And they were very generous. They gave me some really important feedback. The most important, which I thought was interesting, is of course they want to learn how to address behaviors, we all do, but they also wanted a roadmap. They wanted a guide, like how do I navigate the supports and systems so that we can live our best lives? And so my colleague and I rearranged things. We made the intervention specific to FTD. We tested it with 16 family caregivers, and they came out of the intervention with lower rates of sense of burden, and more importantly, a higher sense of confidence in their abilities to manage the behaviors and manage the system so that they could get the support they needed. And while it was a small sample, what that did is it gave us the information we needed to apply for federal funding from the National Institute on Aging to test this on a larger scale. So overall, FTD family caregivers are very generous with their time. I've learned a lot. I thank you for those who helped me out. And I really hope that we can move this forward so we can give families a very specific FTD intervention. Thank you.
Thank you, Allison. Dr. Morhardt, will you talk a little bit about your research?
Okay. I wanted to start with just a little bit of a story. I was a social worker at Northwestern when our director, Dr. Marcel Mesulon, and Dr. Sandy Weintraub were recruited to begin an Alzheimer's Disease Research Center at Northwestern. And it was at that time that I joined them. And what I have learned from them has really fueled my career and my thinking about dementia disorders. because they came with this theme for the center called the heterogeneity of dementia. And what they meant by that is that not everything is Alzheimer's disease, and that and also exposed and introduced us all to the FTD, particularly the language variant, primary progressive aphasia. And it was also at that time that we learned, or I did more, about neurocognitive profiles, and that not all dementias, even not all FTDs, not all PPAs present in the initial symptoms in the same way. And so we developed this care pathway model of tailoring education for families, patients and families, that persons living with the disorders and their families, and the interventions, or what would help. We began to really focus on tailoring that to the specific symptoms that people had. It's not a generic dementia. Everybody is presenting very uniquely and very differently. So then I had the opportunity of working with Dr. Ken Hepburn to help recruit for an evidence-based caregiver intervention called the Savvy Caregiver. He has been running this program since the early 2000s. There's lots of evidence on how successful this intervention is with caregivers, but it is it's pretty global dementia. It's not necessarily specific to one form of dementia or another, and largely maybe Alzheimer's focused. But I helped with that recruitment, and of course, our cohort or our sample is, we have a lot of people with PPA. So I was referring a lot of people with PPA to test this online version of the Savvy Caregiver called TeleSavvy. The families that came back after taking that course, it's a 6-week course, said, something's wrong here. It's a little backwards. They're not talking about language first, they're talking about memory. Mm-hmm. And I'm the only one in the room that has, I'm caring for someone with a non-memory-based dementia. So then I was fortunate then to get some pilot funding from Dr. Hepburn's Roybal Center at Emory, and I did a pilot of a PPA telesavvy. I mean, this is a program that has a lot of evidence behind it. I want to see, can we adapt it? It's not just it's really actually, can we adapt it to meet the needs of PPA caregivers? The first thing I did was I gathered all those people that had taken that class and said, I need to learn from you what fit, what didn't fit, and what was missing. And they were very helpful in doing that. And we took what they said and made those additions and adaptations, and then piloted a 6-week session last spring. We're getting ready to launch another one in June. But I wanted to give that background because I think it really just kind of is a story of how I got to be where we are right now.
Yeah, thank you.
And they're helping me do it.
And I'm sure that resonates with many of you here in the audience today. So Dr. Gaugler, can you talk a little bit about the BOLD Public Health Initiative?
Sure. Wow, it's loud, that mic, I'm sorry. I apologize. I don't know about you. I'm drowning in acronyms, and I'm going to give you another one, and this one is BOLD. But let's do our best here. And I promise I won't keep you from the happy hour either. So BOLD stands for Building Our Largest Dementia Infrastructure. It was passed by Congress in late 2018, and really what BOLD did was task the Centers for Disease Control and Prevention with doing 3 things. The first was to identify and fund 3 national centers in 3 topics of public health import as it relates to dementia. So there's one center that focuses on risk reduction. That's out of the Alzheimer's Association in Chicago. The second focuses on early detection, and that's funded out of the New York University. Josh Chodosh and Sue Borson, two very dear colleagues, run that center. And then there's a third center on dementia caregiving, and we're lucky enough to have that at the University of Minnesota, which I direct. The other thing that BOLD does is it also funds states, departments of health, to advance their work in dementia. So why does this matter? Like, why does it matter to you? Many states, and we've learned this really through engaging with many departments of health, they don't really see dementia sometimes as a public health issue. They see dementia as, well, that's what the Aging Service Network does. That's what the area agencies on aging do. But in fact, and I'm sure you've heard a lot about it today, one can make and should make a very strong case that one, dementia is a public health imperative, and two, dementia caregiving is a public health imperative.
I'll clap to that one, I think.
Yeah. And so what's exciting about BOLD to me is it's trying to break down what I think is a plague cross-cutting dementia, which is siloing. You look at public health and the Aging Service Network siloed because of how they're funded and how they've operated traditionally. Lord knows there's a major silo between academia and the real world. That's another silo. And the list can go on when we think of how healthcare is delivered and how it's siloed and how oftentimes that's working in contraindicatory terms to how we optimize care for people living with dementia. So that's what excites me about BOLD and why I think it's important. It's how can we break down the silo? How can we work with departments of health and other public health agencies to, number one, identify dementia and dementia caregiving as important and as something they should do, and secondly, is to engage the traditional impetus of public health, which is empowering communities, surveillance, advancing policies and practices that optimize the care people living with dementia and their caregivers receive. That is really what BOLD is trying to do. And I guess at this point in my career, I enjoy being part of BOLD because it allows me to say things and offend people sometimes that traditionally I wouldn't have done. I think many of you know there's a lot of turf that happens where people believe this is our topic. You shouldn't be encroaching on this. We do this. And in fact, for us to overcome the many, many challenges I know many of you live with on a day-to-day basis, we have to break silos. That's the point of BOLD, and that's why I'm excited why we're part of this initiative and excited why I'm here today. So.
Yeah, thank you. So I'm going to ask a question, and we'll let you guys kind of answer. So one of the things, I think this question is for Allison and Darby. Can you talk about some of the unique needs that are really specific to FTD that you guys noticed in your research and even in your clinical practice? Because you both see patients every day.
Yeah, the thing, I'm not sure if you would describe it as a need, maybe, I'm not quite sure, but what I noticed in my work, I also run the FTD support group at the University or OHSU. There is a powerful drive with these families to maintain the agency and dignity of their family members. And I see that across the dementias, but there's something a little bit different about FTD families, perhaps because it tends to affect younger families. Perhaps there's the behavior issues, but there's a real need to protect that dignity. And I really admire the effort that the families that I work with do to that effort. I also just very much appreciate what you're saying, Joe. And in Oregon, we have some small BOLD funding for the Native American community. And one of the things I think there's a need for is moving my intervention, my work beyond the white community and making it a richer story. So that's another area that I think the BOLD funding can help with, and an area that we need to focus on.
Agreeing with everything that Allison you've said, and building on that in terms of the work that I'm doing now, I think we need, some of the unique needs are around education and more specific education for behavioral variant FTD, the motor variant, and for primary progressive aphasia, the subtypes. there's not the narrative, and there's a lot of information about Alzheimer's disease out there, but there isn't enough about the different FTD disorders. You know, that AFTD has done an amazing job of getting that word out. One thing, though, that the caregivers that went through those and told me, one of the themes they told me in the focus groups was that they, or actually as a result of the pilot session, is that they didn't realize that the primary progressive aphasia was going to affect other cognitive domains as it progressed over time. They thought it was just going to be a strictly language progression. And even many caregivers of ours come to me and still are not able to quite grasp that this is something that's going to affect other behaviors and other symptoms. So I think that these are unique needs. It's educating and then being there over time as things change. And then I love what Dr. Miller said today, that, and even Allison and I were talking, how can we tell you what your unique needs are? You know what they are, and you need to tell us.
Yes.
And Dr. Miller said, you are the clinicians. You're the first clinicians.
That's true.
And we really do need to continue to learn from you.
Nice.
So speaking of education, one of the things that I think a lot of caregivers struggle with is they end up being tasked with educating their own healthcare professionals who are supposed to be experts in their field on the disease that they've now been diagnosed with. And so I wanted to see if we could talk a little bit about how can professionals better support those living with FTD and their care partners. And I thought maybe Allison and Dr. Gaugler could answer this question for us.
Go ahead, Allison. I'll go next.
How can families help their clinicians? Is that what you're asking?
I think, how can health professionals do a better job supporting people with FTD?
Learn.
Yes.
It's when I was writing this grant proposal, my peers kept saying, "Oh my gosh, it's such a rare disease," and I'm like, I don't think it's that rare, but unfortunately, I think that when people come into the type of work that we do in neurology, it really isn't on their forefront. And to be quite frank, talking about making people mad, in Oregon, not all neurologists, some of our neurologists refuse to even see people with dementia. So they don't even see people, they don't even go down that road. And I feel so sorry for them because it makes our lives so much richer and so much more interesting. And so I think if we can convey our passion for this kind of work and teach them how much better it can make their professional lives if they learn not only about dementia, but about FTD. In Oregon, like all over the world, frankly, we have what are called ECHO programs, which provide free education to clinicians about a variety of diseases. And in Oregon, we're working very hard to make sure that in our, what we call our Dementia 360 series, that they do get education about FTD. And then we also will be starting a program this summer, I was telling the rural health team, called Curbside. So hopefully clinicians from all over Oregon, and frankly, I don't care where they come from, it's online, where they just talked with us about their challenging cases. And I'm really hoping through that, we can also teach them about the very different types of dementia and how to address them.
Yeah, I mean, this is a great question, Esther. And I think at one level, we approach it from the individual care provider perspective, which is, how can we engage care providers to be more knowledgeable, and how will that happen? But I think there's also a structural perspective to think about here, which is what are care providers incentivized to do? And are they incentivized necessarily to provide what we would consider optimal dementia care, whether it's in the case of FTD or not? Or are they incentivized to simply ignore it and not screen for it at all? And I'm just talking about screening. I'm not talking about identifying whether the cause of dementia is FTD or not.
Yeah.
What we know is many primary care providers don't want to have that conversation, still believe there's nothing that I can really do, and leave it at that. And that's where we see these kind of the sequelae of adverse outcomes that can occur during the course of dementia. Again, I don't think I'm telling you anything that you don't already know about, am I? So to me, you know, when I think if you want to change the needle at the professional level, and this is where when we're talking, I think a later question is going to talk about advocacy, whether it's AFTD or whomever, is to what are the professional competencies that providers are trained on and essentially, you know, certified on a regular basis? Do they have anything to do not just with dementia care, but with geriatrics? And starting there as a starting point. And, you know, other colleagues of mine have really made this point. If we're going to move the needle from a larger scale perspective, we have to understand the structure of healthcare delivery and how we change incentivizing for it. Now, one would hope is if we move more and more towards outcome-based care, it would become very apparent to healthcare systems, at least, that, you know, who is driving all the costs based on poor outcomes? Guess what? It's going to be probably older people with complex conditions, and in all likelihood, and this is, again, where I have problems when people say call Alzheimer's and or dementia one of multiple chronic conditions. You can make the argument it's the chronic condition, because if you have dementia, it complicates the management of all the others. So with that in mind, again, if healthcare systems are going to be penalized for poor outcomes for these types of complex, you know, quote unquote complex individuals, one would hope that they would be further incentivized to adopt models that, quite frankly, we know work, and to implement them at scale effectively. I mean, may I make another opinion here?
Go for it. We have time.
You know, we talk a lot about this. There's this idea of evidence-based programs, right? You know, you must adapt evidence-based programs, you know, and you will do that. And many, many places are, again, funded to do that. And as a researcher, of course, I agree at one level for that, but at one level at that. But it's getting a little bit what Allison and Darcy were saying before, which is, you know, if we truly are going to engage with communities and listen to people like you, we have to open up our thinking to what are some of the exciting care models that are happening in communities that aren't evidence-based or even evidence-informed, but really are working. And how we as researchers should really flip this idea of imposing an evidence-based intervention in a healthcare system or community, and instead learning from innovations that are happening in communities and taking them to healthcare systems and studying them that way. You know, I mean, I believe that a lot. You know, I mean, it's not really a secret, but it kind of is, I think, to many, is from the point of basic scientific discovery to actually implementing something in a community or healthcare system takes around 20 to 30 years. And only 14% of those evidence-based innovations are actually implemented. How wasteful is that? I mean, it is, some people, I certainly consider that an ethical imperative, that we're wasting all these resources and time and investments on research that isn't getting to you. We have to rethink the way we do it. And one way I do believe is through true engagement. Listening to you, creating person-centered care models and person-centered measures so we can best capture what's working for you in your situation. You're hearing, you know, examples of this from Allison and Darcy, and I think we want to expand that and should expand that on a more structural level. So,
Nice.
Thank you.
Thank you.
I agree. So our last question is, there are some issues that FTD caregivers face are universal among dementia caregivers, and such as paid family caregiving, which is a very big issue for caregivers right now. How can caregivers better advocate for the support that they need? This is an issue we hear over and over again on the helpline from families, is that very often in the FTD space, our caregivers have to advocate for the services and the things that they need so proactively. So do you have any advice or tips or ways that they can better advocate even on a macro level within maybe some of their state plans or, you know, on a public health space? And that is for Joe
Okay.
and Darby Morhardt.
Okay, that's great. Thank you. I'm sorry, Darby. I was calling you Darcy. I'm sorry about that.
It's okay.
I think the most important thing, and you heard Esther allude to this, is if one is trying to advocate for issues around FTD, is having one's voice heard around the table at these state dementia plan initiatives. I can speak for the state of Minnesota, but I think many other states operate in a similar fashion. When these state plans are usually assembled, they bring together a wide coalition of stakeholders. It will include healthcare systems, usually departments of health, certainly the Aging Service Network, and then people living with dementia and their caregivers themselves. And if there's one way to at least get on the table the needs, and then potentially those services that should be disseminated or implemented to address those challenges unique to FTD, that is one possible way. Now, that's the optimistic answer. I mean, there is a more skeptical answer I could provide, which is, and I've seen this with some of these state plans. Now, hopefully BOLD is trying to ameliorate this, which is, this is what happened in Minnesota. We put together an awesome plan. It was great. This was back in 2018 or 19. Multiple stakeholders engaged across the state, rural communities, communities of color, representing the span of causes of dementia in terms of stakeholders. It was really good. We put a lot of work into it. You create the plan, and then what? I mean, is there a plan to implement any of the recommendations? And I remember very clearly at this meeting, I'm not like this all the time, by the way, so, but I remember at the first meeting in 2018, I had asked, everyone was very proud of the plan that had preceded, which was 2011. I said that it was a great plan, a lot of good ideas. Did anyone track whether any of it was done? Not an answer. It was total silence. And that told me what needed to be done, correct? So if you're advocating, it's one thing to advocate, here are my needs, here are my concerns, here are my services, is to then advocate for that second step. We can't just continually go over and over again what the concerns are. It's also about, okay, what can we do in a scalable, reasonable way to act and implement plans to address them? And again, this is where your voices are as strong and can be as strong as anyone else's. So please remember that if you are advocating for FTD in whatever capacity.
Could I speak to that? Do you mind if I speak to that? I just wanted to speak to that with a real life example, Joe. I was very, very proud of Oregon and our state plan because we are working towards teaching primary care providers across the state how to diagnose any type of dementia and diagnose. So the bill went before the legislature and it received very strong opposition from one of the psychological communities saying it's dangerous, people get a dementia diagnosis, they're gonna hurt themselves, and I went right to my FTD support group, I called Scott, I said we gotta get these letters out there, and our support group team totally went to town. They wrote these very vivid, beautiful letters. I don't know the outcome yet, but that's a direct example of how your work really can change things.
That should be a session for a future conference here, is literally is policy advocacy and how can you change the needle at a policy level? I think that'd be very important.
How can we change the Alzheimer's state plan to
That's true. That's
a more
that's
broader
That's true.
state
Yeah, that's
plan?
I agree.
I'm involved in the I'm involved in the Illinois state plan.
Right.
That it happens to be under the Illinois Department of Public Health.
Oh, great.
But the Department on Aging has their own state plan.
Yeah,
Just
see,
going
well,
back
now-
to Joe's idea, we're all working in silos. These are things that do need advocacy and policy change.
Yeah. I am so sorry that we're done having this conversation because I think I could sit up here for another half an hour.
No.
I really, really want to thank the three of you for all of the work that you are doing every day to support FTD caregivers. We really appreciate the research you're doing, the advocacy work you're doing, the work in the state plans. If you haven't already, I hope that you will come and talk to our wonderful panelists after the session today. But at this time, I am going to thank you all for your time.
Thank you.
And we are going to bring to the stage for our final session of the day. Please welcome Sharon Denny back to the stage. Huh?